So Stacy Greeter is double board certified in both child, adolescent, and adult psychiatry and owns a group psychiatric practice in Sarasota, Florida. She speaks from both her lived experience as an autistic, ADHD, and OCD individual and as a clinician. Dr. Greeter graduated summa cum laude from Duke University and went on to the University of North Carolina School of Medicine on a full scholarship. I'm curious about where her allegiance lies with both Duke and UNC, but we
I
can
can
get to
tell
that
you.
later. Okay, yeah. Um, Fill me in at the end.
Okay.
Dr. Greeter completed her residency at Northwestern Memorial Hospital and continued there to complete her subspecialty fellowship in child adolescent psychiatry. She believes in cross-pollination of knowledge between disciplines, creating space for safe, candid conversations on controversial mental health issues, and runs a multidisciplinary mental health professionals book club and co-hosts the podcast Chronically Real and Clinically Relevant. Dr. Gruder teaches at Lake Erie College of Medicine and Florida State University and is on the board of directors for Autism Career Pathways and NAMI Sarasota Manatee County and on the leadership team of Autistic Doctors International. Dr. Gruder uses metaphors from fantasy universes such as Star Wars, Lord of the Rings, and The Little Mermaid to make psychiatric concepts accessible and engaging through her educational psychiatry boot camp series. Some really fun stuff there that I am excited for. I have seen her speak before, and that is the reason why we wanted her to come here. It's a really engaging talk, and I'm excited to turn it over to you, Stacy. So take it away, and if I can help with anything along the way, just let me know.
Thanks so much, Ben. I appreciate that, especially since I wrote way too long a bio. Um, okay. So to answer your question, I have to say my allegiance lies with Duke, where I went for my undergraduate. I did switch over to UNC Chapel Hill. I got a scholarship to med school, so it worked out. And but my allegiance has to lie with my original undergrad. But you know what? I would say for us, Dukies, we're pretty much cooler with UNC than UNC is with us, you know? So I think it works out. Um, so I spent a while in North Carolina. I love it. Um, and like you said, yes, I am a child, adolescent, and adult psychiatrist, and that's my contact info, their website, YouTube channel that has other fun fantasy themed videos. Here is our dragon themed presentation on OCD, in case the dragon horns weren't enough of a hint. All right. I'm focusing this talk on a lot of info on medications as a psychiatrist. Um, SSRI medications, the mainstay of our OCD treatment, of course. Um, you want to start them at smaller hobbit doses, but you want to titrate them to really big dragon dosages for OCD. Why is that? Because um, people who have OCD and people who have anxiety have a higher risk of getting activated when starting the medicine, like edgy, restless, irritable, or an increase in anxiety. And when you have anxiety, side effects in your body are like on a loudspeaker. Okay. So you want to start smaller because you want someone to be able to stick with the medicine. Okay, we're playing a long game here, but we need a much higher dose than the typical doses for depression and anxiety to actually treat the OCD. So it's a process. All right, what does that actually look like? Here are the actual doses. Starting doses, okay, like 10 milligrams of fluoxetine. Sertraline, I usually start at 25, but sometimes 12.5. Um, Fluvoxamine, I love that one. Luvox, I don't think it's used enough. Escitalopram, starting at 5. All right. Now, the kind of doses that we end up on for depression and anxiety are these dosages. Um, and the, top dosage here is often the quote FDA maximum dosage. However, um, that is an FDA dosage that is decided based on studies of depression and anxiety, not studies for OCD. So for our OCD dosages, okay, we're going up to much higher doses. And I think this is a really important thing to emphasize because I think a huge percentage of OCD patients are underdosed when they could possibly have a great response if we went higher up. And I'm also emphasizing it because um, it's tough. You're a patient, you have some health anxiety OCD, you go to the pharmacy to pick up your medicine, and they're like, do you realize how high a dose this medicine is that your doctor prescribed you over the FDA maximum? And you're like, I'm freaking out. So that's why I think it's really important to recognize, and even if you're not someone prescribing, but you're a therapist working with a patient, to be aware of A, is your patient getting an evidence-based treatment and actually getting like adequate dosages? And B, helping that patient field like all kinds of anxiety provoking statements from their pharmacist or their primary care, etc. So with a partial response to a medium dose, you definitely want to go to a high dose. No response to a medium dose? Yeah, I'm probably going to switch the medicine. Now, let's talk about side effects. Um, you know, and how we manage them. I think side effects are probably one of the biggest reasons that people have difficulty staying on the medications. So, nausea is common because there is a lot of serotonin receptors in your gut. There's actually a higher number of serotonin receptors in your gut than in your actual brain. Um, the biggest thing for nausea, um, go slower in titrating it, taking it with food, dividing the dose up twice a day instead of taking it all at once, and Zofran, also called ondansetron. So Zofran is a nausea medicine that actually has data for helping with OCD. So it has, I mean, hey, does it have a huge amount of data? Is it a heavy lifter like our SSRIs? No, but why not? If it's going to treat your nausea and maybe augment your OCD symptoms. I will say Zofran is constipating. So if someone is prone to constipation, they want to do Reglan instead, which is actually acting on the dopamine system for their nausea. All right. Sexual dysfunction. While nausea, most of the side effects you have with an SSRI tend to dissipate over time. The nausea tends to dissipate over time. Um, the sexual dysfunction often does not dissipate over time. And I really want to emphasize, guys, there is hope. Okay? Just because you need OCD medication does not mean that you need to give up on orgasms for life. And it's really important for this side effect to be discussed up front with patients because um, it's hard to bring this up with their psychiatric professional. So, like giving them a heads up, like, yeah, a lot of patients on this medicine may experience difficulty with arousal, difficulty with erection, difficulty with orgasm. I want you to know that it's totally normal and does not embarrass me at all to talk about that stuff. When that happens, can you please bring it up and kind of priming them for these side effects that are harder to bring up? So if the issue is difficulty or delayed orgasm, stuff like Cialis and Viagra is ideal, and that's taken as needed an hour before intercourse. If the side effect issue is low sex drive, difficulty with arousal, buspirone. also called Boost Bar, is the most ideal choice. Another side benefit of Buspirone is it tends to help with anxiety too. So that's really nice. Um, Wellbutrin, not as effective as the Buspirone and the Cialis options, but has some good data. Now SNRIs do have less sexual side effects than our SSRIs. So those are serotonin norepinephrine reuptake inhibitors. And unfortunately, they don't have as large a body of data for OCD, but I do find, I will tell you clinically, I do find that they work. So, some patients, some of my OCD patients, let's say they come in on a super high dose of Zoloft and they're like, I have sexual dysfunction. I don't want this anymore. What sometimes they end up on a combo of a SNRI with some buspirone, for example. All right. Excessive sweating is common, and I use glycopyrrolate. Super easy. It's like 1 milligram twice a day. Sometimes the sweating only bothers them at night, so I just do 1 milligram at night. Teeth grinding, Buspirone helps with that, and then activation. That's when you get edgy and a little increase in anxiety. If you start at a lower dose or go slower in titrating the medicine, that can help, or maybe you need to switch medicines. Increased sadness or hopelessness and suicidal ideation, that is a no-go. We have to change the medicine. Whereas these other side effects, we could generally kind of work with them. Any questions on these side effects before I keep going at all? And if not, that's cool. I'm just going to give some space if anyone has questions about side effects and addressing side effects. Okay, so um, psychotherapists, allies, can be really pivotal in helping us psychiatrists set up positive expectations of the medicine. So here's a cool study. Um, there's 27 people. They're all given the same exact medicine at the same exact dosage. In the study, they lied to the people and told them, some of them, that they were not getting medicine and they were in fact getting some made up thing that would give them all the side effects of the medicine and none of the benefit. So, as you might predict, okay, um, the treatment response of people who expected they were getting beneficial medication was 4 times higher than the response of people who expected they were getting some substance that would harm them. I emphasize this because, and we know this, expectations of medication matter. Okay, so helping set people up to have some positive expectations of what the medicine's going to do. Even more interestingly, okay, um, when they did PET scans, okay, serotonin transporter occupancy was the same in both of these groups. But the group that was expecting to be harmed by the substance differed in dopamine binding. So we have two separate systems. We have the serotonin system that's mediating the psychopharmacological effect, chemical effect of the medicine. And then we have the dopamine system over here that is modulating that person, the effect of that person's expectations of the medicine. And the fancy name for when we expect side effects and we get them um, is called nocebo effect. So placebo effect is when you expect something to be beneficial, so it helps. Nocebo effect, you worry that something is going to harm you, so you experience harm. And don't get me wrong, side effects are very real. And by the way, nocebo effect and placebo effect are very real too. as you can see, there are differences in a PET scan and differences in transporter binding. Minorities, so here's a study. Minorities, also females, people who are disenfranchised, okay, more disenfranchised populations experience higher nocebo effects. They also experience more medical mistrust. Medical trauma, I'm sure, plays a role in this too. Okay. How many of our OCD patients have experienced medical invalidation? Um, and so we're thinking about how that plays a role in our patient's response to the medication. And then when you have more side effects, you have poor medication adherence, you have a higher symptom burden. Um, so what do we do? Well, um, we really want to emphasize autonomy, okay? So people who feel more empowered are less likely to have nocebo effects. As psychiatrists, we want to welcome disagreement. We want that patient to be as comfortable as possible expressing disagreement with us very openly. There's a quote. It was Dr. David Mintz. I'm a fan of his stuff, and I have a Star Wars theory series on my YouTube channel on psychodynamic psychopharmacology, FYI. If you're into that, uh, stuff like me. But David Mintz's quote is, patients who are unable to say no with their voices may do so instead with their side effects. So you really want them to be able to say no with their voice. Okay. Um, I emphasize to the patient their autonomy to discontinue the medicine at any time. I say, you're dating the medicine, not marrying it. Okay. Just just talk to me. And maybe that's part of the process. I think one thing that gets under my skin sometimes is when people are like, oh, well, maybe medicine doesn't work for you. I'm like, no, there's not like some, okay, special like species of human being where medicines don't work for them per se, but that person may need a lot more medication trials. I'm also going to throw out there too, as an autistic and ADHD person, that neurodivergent people have more unexpected and idiosyncratic side effects to medication. And we'll need, it doesn't mean meds don't work for us. We need a larger volume of medication trials to find the right fit. So that might just be part of the process, um, which is hard. And then I think in psychotherapy, you can also explore like what are some things that taking medicine means to that person. Does it mean that they, you know, are weak? Are they, does it mean something outside is controlling them, or intruding on them? So, what does taking the medicine say about you? Does it confirm that something's really bad wrong with you? Um, and kind of reframing taking medicine as a strength, that it takes a lot of courage, that using every resource at your disposal to live a fulfilling life is a strength. Um, so often our OCD patients fear being, they fear a loss of control, right? What is the medicine going to do to me? They fear a loss of identity. Is it going to change who I am? Like my brain chemistry is going to be permanently changed and I'm going to become this other person. They fear dependency, right? What if I'm stuck on the medicine forever? Um, and when we're talking about the medicine, I think there are ways that we can help really helpfully reframe it for them. Um, we might be used to saying, oh, well, the medicine will, um, decrease your anxiety. And perhaps instead, reframing the medicine as enhancing autonomy would sound like on the medicine, you can choose to more easily let go of anxious thoughts. So that's an enhancement of autonomy. Or on the medicine, you can be your more authentic self, not held back by OCD or weighed down by OCD. So in that way, medicine is enhancing authentic identity. Um, and exploring the patient's relationship with their psychiatrist. That is going to impact treatment a lot, of course. Onward. What does the patient's family think about psychiatric medication? Um, are there certain spiritual or religious beliefs that using medication means turn that they've don't have enough faith? There could be some great spiritual leaders to refer them to. I'm thinking of Katie O'Dune and her stick with the ick um, stuff. Reverend Katie O'Dune, she's really awesome. And Rabbi Noah Tile is really awesome too. I've gotten to work with both of them. Um, their family of origins, attitudes towards medication and stigma in their family. And I put this in yellow, like a bright yellow color, because I don't think we talk enough about the patient's hopes for medication. I like to ask patients, like, let's imagine I prescribed you the most amazingly helpful medication ever. What would your life look like on this most amazingly helpful medication in 6 months, right? So, what is their expected benefit on the medicine, what they would love to get from it, and also their role, right, in monitoring this, communicating, as kind of coaching patients to assertively engage in their psychiatric treatment. I mean, okay, I think it's kind of an issue with society that we expect people to like know what they do in their role as an effective patient, right? I have a handout I can email to anyone if you email me. It's called The Struggle is Real, How to Win at Being a Psychiatric Patient. And it really goes through like what is your role to be an effective psychiatric patient? Um, and so coaching people on that and how to get the most out of their treatment, I think is really helpful as opposed to just expecting people to know what they're supposed to do as a patient. Um, I'm always loving to give resources for a deeper dive. Um, Psychiatry and Psychotherapy podcast has a really cool episode on OCD medications. And a cool thing about it is that if you go to the podcast notes, it's got like a huge written summary, and the different doses of the medicine. So that could be a resource. Here's a table I've referred to on Psychopharmacology Institute to help patients see, how high we can go with their OCD medications. Um, International OCD Foundation, the doses listed are too low, actually. So they're fixing it. So yay. Um, they're updating that for us. So this is really good. Um, I think that that's really helpful to people, to help them really get up to those higher doses. Some more articles in case people want to get into like where I got the algorithm from. Let's go beyond SSRIs, augmentation strategies for the medicine. Okay. Um, Luvox, fluvoxamine, and clomipramine. Clomipramine is a tricyclic antidepressant, so it's in a totally different category than an SSRI. And these two augment each other super well. Um, clomipramine, you get to check a blood level, and there's actually a target blood level that's most therapeutically effective. Um, the fluvoxamine inhibits the metabolism of the clomipramine, which is a good thing because the more clomipramine is hanging around and the less norclomipramine, its metabolite, the better for the patient. But you also gotta like check a blood level and check an EKG. Okay, tricyclics are dangerous in overdose. Um, and that is because they can cause cardiac arrhythmias. So this is something to be cautious about. And I'm always telling patients, like, if you're feeling suicidal, right, it's time to lock up the clomipramine. It is super hard to actually have a fatal overdose on an SSRI. That's like not really heard of so much, but you can do that with a tricyclic antidepressant. Um, so other augmentation strategies. My personal favorite is the clomipramine augmentation strategy. It's really effective. Um, Atypical antipsychotics, like Risperdal and Abilify, also called risperidone and aripiprazole. Um, those are the two atypical antipsychotics with the most evidence to support augmentation of your SSRI. There's a little evidence for olanzapine and quetiapine too. Um, these medications do cause weight gain. They also can increase your risk of diabetes. So it is really important that we start patients on metformin to help prevent diabetes. Pretty much, if a patient is anything other than like extremely skinny, really needs to gain weight, I am starting them on metformin at the get-go um, because it will decrease weight gain and decrease risk of diabetes. Um, and so you do need to monitor cholesterol, and also elevated cholesterol is a risk of these meds. So you got to monitor cholesterol and you got to monitor blood sugar with these guys. But they're pretty effective for augmentation, and a lot of people are not going to get enough from a single medication strategy. NAC. I'm like, oh, it's cute. It's basically harmless. Why not? I mean, yeah, NAC is not as heavy a hitter at all as the Abilify, risperidone, or clomipramine strategies. It's true that like there are patients who come in, oh, I really want to use something natural. They feel like more in control and more autonomy if it's something they can buy over the counter versus a prescription, you know. So I'm thinking about those things. Um, and sometimes I'm using that to kind of build a therapeutic alliance. It's acting on the glutamate system. This is first line medication, NAC, for skin picking and hair pulling, FYI. And I would say my favorite glutamate strategy is memantine. Um, So, and there's maybe some data that especially in the autistic population, memantine is pretty cool. Um, Again, not going to be as heavy a hitter as your risperidone, your Abilify, and your clomipramine augmentation strategies, but very benign in its side effects, at least. So that's nice. All right. Farther down the treatment algorithm, okay? We have some other stuff, but I'll be honest, it's pretty far down the treatment algorithm. You know, Smaller effect sizes, but you can try it out. Minocycline is actually an antibiotic. Um, so what about stimulants and ADHD? Okay, I'm just making a note here. I think stimulants really get like a bad um rap for whatever reason. And people think, no, you can't be on a stimulant if you have anxiety and OCD. No, okay, if you have ADHD, and you also have anxiety and OCD, the first line treatment for your ADHD is still a stimulant. Um, it is true. Some people are going to have worse OCD on a stimulant. It can happen. Many, many, many people, I would say more people, have an improvement in their OCD because they have more autonomy to regulate what they focus on and what they tune out on the stimulant medication. So, don't be too scared of it, please. Um, and it's worth a chance. And there's actually a study here. Okay, this was on a combination of the SSRI fluvoxamine and extended release methylphenidate, which is a stimulant for ADHD. And they found that it improved OCD symptoms in these people. So, cannabis. Unfortunately, the data is that it is not good for the OCD. So, in these studies, when patients started the cannabis, they'd experience like a short-term, like temporary decrease in anxiety and OCD, but over the long term, they actually had an increase in symptoms. And so it's sort of like they develop a tolerance quickly and they end up worse on the cannabis. But I think that's important to note because um, it could be hard for a patient, like if they experience short term a decrease in their anxiety, to recognize that something in the long run is elevating their baseline level of anxiety. Sometimes I bring up with patients, I'm like, Freud used to use cocaine to treat depression. He also used the cocaine himself. Um, and he thought it was great because in the short term, right? People are like, yeah, my mood is much better. Not so great in the long run. Here's a bunch of research about cannabis and OCD. Wah wah. All right. What if the patient is bipolar and OCD? It is tricksy. It is, okay? Because unfortunately, since SSRIs can easily precipitate mania and destabilize bipolar disorder, it is limiting us much more in our OCD treatment options for bipolar patients. Um, Clomipramine, you're not going to be using that in a bipolar patient either. It really does have a high switch to a manic episode. So we're going to be leaning into the risperidone, aripiprazole, memantine, for example, in these patients. Um, and bipolar disorder is not like it's not a black and white dichotomy between regular depression, unipolar depression, and bipolar disorder, where you have both the depressive episode and the high highs of mania. Um, it is more of a spectrum, okay? Where, on this end is just the depression. On this end is a severe manic episode. Somewhere in the middle is like, I'm a little hypomanic, right? So you're like, where is this patient in this spectrum to kind of decide, can I safely use an SSRI with a mood stabilizer on board? It's complex,
Bipolar disorder and OCD. Very tricksy.
very tricksy. Okay. Another non-medicine treatment options, deep brain TMS. It's very important that an OCD patient isn't just getting regular TMS. Okay, the regular TMS does not work for OCD. Only deep brain TMS, which targets a different area of the brain, the deeper brain structures, is effective for OCD. And so the patient may need to advocate for themselves to make sure they're able to get that treatment. Um, so, these deeper structures, it's kind of the corticostriatal thalamic cortical loop, okay, um, is what we're targeting here when we're targeting OCD.
Base diagnosis on patient's internal experience, not just their external behavior.
Or else, yes, as Smog says, base diagnosis on patient's internal experience, not just their external behavior. We're going to do a little bit of dragon differential diagnosis here. Because I would say one of the most important things in doing effective treatment, and especially if an effective medication treatment, is a solid differential diagnosis so that we are treating the right thing. So distinguishing some OCD lookalikes. So you're not trying to treat something that is not OCD with OCD therapy and OCD meds, which commonly may co-occur with the OCD. All right. So, this is Smock, okay? I'm describing his OCD. He's like, I see the Arkenstone and like dread comes over me. It's like I have to have it facing just right or something terrible will happen. Maybe my friend Drogon will die. Then I have to fix the other gems. But then if I touch one side, I have to touch the other side. If I don't, I might be stuck with this just not right feeling forever. Okay? Um, so you see how it's very classic, the OCD feel to it. That stuckness. I know it doesn't make sense, but I must do it. I have to, that compelled to, um, and that dread, or else something terrible will happen. Um, versus Autistic Dragon is describing his treasure sorting. All right, this one actually has an audio with it.
When the outside world overwhelms me, I can escape to my treasure pile and research my artifacts and find new ways to arrange them. Species of origin, chronology, material composition, so many options. I like to create new systems. This helps me recharge. When I have to go out and talk with other dragons, it's really a drain. Unless I find a dragon who wants to talk about elven artifacts from the Elder Days, before Valar was driven from Arda. Then I could go on forever and wonder, where did all that time go?
So you see, um, both of these dragons, same external behavior of spending a lot of time with treasure sorting and treasure organization, as dragons may do. Um, but one of them, well, this one, um, you see that it's fulfilling for them. It's something they enjoy. Now, from the outside perspective, right? Parents of this dragon or, other loved ones might be like, oh, they're so OCD because they're doing this so much. Colloquially calling it OCD, when if you dig into it, you realize their internal experience is one of kind of an intense creative flow state where they don't realize time is passing. It's rejuvenating, it's regulating for their nervous system. And so that's going to be an autistic special interest or autistic stimming, perhaps. So stimming refers to repetitive, predictable input from the environment that's regulating to the nervous system. And they connect with other dragons through talking about their special interest. Um, Okay, another dragon, OCD lookalike. Oh wait, never mind. A Venn diagram is next. So, distinguishing these, OCD, the person wishes they could stop, right? Autism, if it's an autistic special interest or STEM, they experience greater distress and dysregulation if forced to stop. Um, in OCD, their repetitive behaviors are driven by fear. In autism, repetitive behaviors are emotionally regulating. And um, the routines are there to give predictable input so that you know what to expect. Um, and a monotropic attention style refers to how the autistic person gets hooked on a particular thing and their attention is really drawn in deep to it, and they need to go deeper into that special interest maybe than other people do. All right. Also distinguishing this from tics. I want to note that it gets complicated. An OCD person who is also autistic can have something that starts as a special interest that they get a lot of joy from. And then, unfortunately, like they're loving sorting their treasure, OCD can take a hold of it and it can create a narrative and make it a compulsion. Um, and that's really unfortunate. So things that were previously a special interest or a STEM can become compulsions and be fear driven and completely rule bound and the person be trapped. So tics um, tend to be less complex than an OCD compulsion. But again, a tic can also turn into a compulsion because OCD can really, prey on any part of your life and create a fear-based narrative and compulsion out of anything. Um, distinguishing these things. So stimming, um, that's like rocking, hand flapping. My favorite stim growing up was swinging on the swing set and rocking on a rocking horse. But verbal outbursts can be stems, or even visual things that you like to look at can be a stem. They're usually present from like young age, okay? And they tend to be prolonged and repetitive, whereas a tic tends to be much more brief and simple. Um, Additionally, when you resist a tic, the urge to tic tends to build, okay? And there's this almost physical premonitory urge that builds, whereas generally when you resist engaging in an OCD compulsion, the urge tends to dissipate over time. So, okay, so why is this important? Why? Because the treatment is totally different. Um, for stimming, we collaborate with individuals so they can do what's regulating for their body. If a stim causes harm, like severe head banging, or even cutting, or, we try to help them find an alternative way to get that same type of sensory input. Um, some of my patients like little ouchies, for example. That's a nice stim to help replace other things that might cause harm. Um, there are no meds for stimming. Um, there is um they did studies on autistic kiddos and they tried to treat what they called in the DSM-5 restrictive repetitive behaviors. A more affirming term that we use is stimming with SSRIs. And it didn't work. And then we got this lore sort of this mythology going in psychiatry that SSRIs don't work for autistic people because of these studies. Um, that is false. Okay. SSRIs do work for autistic people, but they do not decrease autistic traits, like engaging in your special interests or stimming. They do help autistic people with OCD and anxiety and depression. Um, it is true that autistic people have more commons are more likely to have side effects to any medicine, okay, just by being autistic, and may have a lower treatment response in general. Okay. So that's one of the reason I get on that whole long explanation. If it is a tic, you're using guanfacine and clonidine as first line, versus if it is an OCD compulsion, you're using SSRIs, SNRIs, clomipramine, etc. So treatment approaches differ. All right. Smog is going to talk just a little bit about neurodiversity affirming OCD treatment.
Before I knew I was autistic, my first therapist told my family to discourage my treasure sorting and elven artifact collecting, and I really felt ashamed of it. Fortunately, after my autism diagnosis, Smeagol found a neurodiversity affirming therapist for me who understood the difference between an autistic special interest and an OCD compulsion. I enjoy sorting treasure and it regulates me emotionally. I understand that Smeagol isn't interested in treasure the same way I am, and that's okay. I balanced my need to spend time with my treasure with doing something Smeagol likes too, like murdering hobbits, because keeping Smeagol as a friend is important to me.
So you're also seeing here that there's a balance between the autistic dragon doing what they want to do and accommodating themselves, and also because they value relationships in their life, accommodating what's interesting to the other person and their needs in kind of balanced co-accommodation. Jeremy Schumann does awesome stuff on neurodiversity affirming care, so you can look him up and watch his videos for OCD specifically, and how we modify exposure and response prevention treatments to and ICBT for autistic people. So just a note on that, right? Um, we want to make sure, I hope this slide isn't too confusing, okay? So the baby is what we're keeping and the bath water is what we're throwing out. And there is also some lore in the autistic community that cognitive behavioral therapy or anything called behavioral is not affirming. Um, and obviously, that is cognitive behavioral therapy, exposure response prevention are our mainstays for OCD treatment, as well as ICBT. I like ICBT too, by the way. Um, Now, exposure therapy, however, can be harmful if we're inadvertently teaching an OCD patient to hide their distress or an autistic patient, trying to change autistic traits or to make someone appear more neurotypical or mask more, that's the right way to be. Masking um, that is hiding autistic traits needs to be taught as a social survival tool, but not just the only correct way to be. So that person can find relationships where they can be fully authentic. Um, okay. So treatment needs to be an invitation, not a command, always respecting agency and autonomy, celebrating neurological differences, really not making assumptions as much, being much more curious and explorative about what works for that individual versus totally prescriptive, um, and free from guard railing or like assuming that someone isn't competent to make decisions for themselves, simply because they're autistic, exploring the function of a particular behavior, um, before you think about trying to extinguish that behavior. And BFRBs, the treatment strategies are different too. So I see a lot of people, unfortunately, getting put on SSRIs for their BFRBs. That's the hair pulling and the skin picking. Um, so interestingly, the types of medications that work for BFRBs tend to be some similar to the medications that we're using for substance abuse. And I do think that there's an addictive quality to BFRBs. So really, medications that act on glutamate, not medications that act on serotonin, are first line for our BFRBs. This is your NAC, your naltrexone. Memantine also, I don't know, for some reason I didn't put it on the slide, sorry, for BFRBs. And while with OCD, we're getting the person to face their triggers, not avoid them. With BFRBs, we're helping them, like, don't go and stand in front of the mirror for a long time, wear gloves, use Vaseline to reduce triggers. Here's some Venn diagram on that, and the different strategies here. Sometimes you can use antipsychotics alone for the BFRBs too.
Base diagnosis on patient's internal experience, not just their external behavior.
Thank you. Thank you, Smog. All right. So, thank you for listening to this long presentation. Check out YouTube if you want to get even more. I will stop sharing my screen and take some brief questions. Sorry, I don't have more time for questions.